So again, my name's Allie. I'm a physical therapist practicing in St. Anthony, Minnesota, which is a suburb of Minneapolis. I live in Minneapolis, awesome city. Come visit if you haven't. Um, no disclosures, just like a little blurb about myself, what brought me here. I went to university throughout the Midwest and then completed my orthopedic residency at mHealth Fairview, which is a large healthcare system in the Twin Cities metro area. I started rock climbing the same time I started PT school when I moved to the cities. So kind of my journey into sports and orthopedic rehab started at the same time as my climbing journey. So it's been a lot of fun to get into it. I primarily boulder indoor, gearing up for Boulder Fest this weekend, but also love to explore the outdoors as well. Right, so I'm talking about a rock climber who sustained a talus fracture. Just to be clear, not this one. Couldn't help myself with this group, but it is the ankle bone. So really important weight-bearing bone in the ankle. So I did not see this climber until a couple years after the initial injury because there was multiple surgeries. So I'll kind of take you through the background. So this is a 36-year-old male trad climber. He fell while leading to a ledge and sustained a very complicated, tricky fracture of his talar neck. Also, he dislocated his subtalar joint, so it was a pretty big injury. To complicate things, it took 24 hours to evacuate. He was in a pretty remote area of Turkey. And so with the swelling in the area, it was developed some compartment syndrome, unfortunately. The model in these pictures and videos is not the climber. It's my spouse and climbing partner, who also has tight ankles. So after the climber finally got to a hospital, he had 2 surgeries while he was still abroad. One of them was to just get rid of the swelling, kind of stabilize the fracture, calm things down, and then another surgery to fixate the fracture. He came back to the States and completed 3 months of physical therapy at an outside clinic. And then he kind of got the itch to go travel again and wandered the country, doing kind of PT here and there at different clinics. And he sort of attempted to self-return to climbing and just ended up being unable to with a lot of pain in his ankle, especially with the approaches. So he ended up moving home to Minnesota where our paths crossed. Completed a 3rd surgery about 2 years later to remove the hardware, clean out the scar tissue. So the surgeon noted a large osteophyte that had developed in the lateral talus, which really limited his inversion and eversion range of motion. So picture a trad climber not able to invert their ankle. It's going to really limit their ability to jam into those cracks. This is just some MRI findings from about a month and a half after this 3rd surgery, just kind of giving you an idea of the status of his osteochondral surfaces. And it was really swollen still, just pretty cranky ankle. And then post-traumatic degenerative changes. So unfortunately already developing a lot of wear on the joint surface because of the traumatic injury. So he and I met, fun fact, he found my name on the Climbing Doctor's website. So thank you, Jared, for having that available.
Absolutely.
Yeah, that was awesome. So he and I met about 2.5 months after that surgery. He had completed a couple visits at a different PT site and was doing like kind of basic ankle post-op rehab. He was still having pain, anterior lateral ankle, right where the talus articulates, and he was still having swelling. He couldn't really get back to a lot of walking. He again sort of tried to go out and climb on his own, and he just had a lot of pain with all of this. He wasn't able to tell me specific climbing movements that hurt his ankle. It was all of it. By the time he finished his approach and got to the crag, like it was too sore to even attempt climbing sometimes. Some things that stood out to me in our first meeting, his subjective history, were some of these quotes. Just unfortunately, after his 3rd surgery, 3rd round of rehab, was feeling unmotivated. Previously, before his injury, he quote, "Climbing was my life." He worked remotely, traveled, finding, like chasing the climbs basically, and having that suddenly stripped away is a big impact. I think Rachel spoke to this a little bit, like the psychological impacts of this injury. So that's kind of the context of his, mindset and everything when he's coming to meet me. He also said he's not great with routine. Like he said, I probably won't follow the program you give me. So that was fun to manage and kind of try to collaborate and do rehab on our terms, not just my terms. So I just listed some of the exercises he was currently doing. Again, he had attempted to climb just once so far, and he was walking, sort of trying to hike. At this point, it's late spring in Minnesota, so we're finally starting to get rid of the snow and get back out there. Of note, like there's no low impact cardio in this current program. There's no strength training, no hangboarding. So things that he probably could have been doing for the last 6 weeks that he really wasn't. Objectively, here's some numbers. I bolded things that really stood out to me. So hopefully you're familiar with the dorsiflexion weight-bearing lunge test, also known as closed chain ankle dorsiflexion, where the foot is fixed on the ground. You're measuring the distance that the ankle can dorsiflex touching the knee. I haven't really learned about any norms. I think it really varies by population, but when you compare it to his non-injured side, it's half as much. As I expected, limited ankle dorsiflexion range. Really all of his ankle movements were limited compared to his non-injured side. Again, inversion. So he had about 0 degrees before his hardware removal surgery. Fortunately, he gained back some inversion, but still not a lot. I like to test ankle strength with calf raises to fatigue. So I've kind of been learned about some norms. I think one that I referenced had healthy males in his age group should be able to do 32 calf raises. So he's close on his non-involved side, not quite there on his involved side. As far as balance control, we couldn't even do a Y balance test. It wasn't productive to get some numbers because he had such a hard time balancing and moving into those movements. So I skipped it and decided to come back to it. So this was kind of my framework for getting started. I modeled it off of Dr. Dave Tilley, who works with a lot of gymnasts. And it's, I suppose, my version of the rock rehab pyramid, which I love to reference. I think that's a great framework. Because we had had a third surgery, we were able to kind of start from scratch and go through why kind of tissue healing and calming things down is really important before we get into back into climbing. So that's where we started. Our first session was all education, just kind of talking about, let's level with it. This was a big trauma. It's not the news you want, but it's kind of the reality of the ankle. And so now here's how we can meet you where you're at with allowing some activity for sure. So I use this ankle energy bank analogy, kind of my way of talking about load management or your stress bucket. So I gave him things that he could do to increase his ankle energy deposits, right? So relative rest, making sure that the term is relative, it doesn't mean absolute rest. He wore just like unsupportive flip-flops, Converse, whatever. So I'm like, hey, maybe let's consider like nice supportive shoe. Listed a couple other things there. I encouraged him to get out and bike, swim, right? So the lakes were starting to defrost. And then really we had to talk about managing those energy bank withdrawals or just not exceeding his body's threshold for activity or capacity for activity. So he would try to just walk it out. Like the more I walk, hopefully my ankle will feel better. And I'm like, maybe let's try to flip that and do a non-impact activity to allow your ankle to tolerate walking later. He would honestly just grab his ankle and try to crank the heck out of it and force it to move. So we did some education about that, and just kind of keeping the joint surfaces happy. We had the MRI to kind of show him that, hey, there's still bony edema in here. We gotta back off a little bit. But I think it was helpful for him to hear, oh, there are some things I still can do. And then I just kind of got right into treatment. So the next couple slides will walk us through exercises we did as examples, interventions, starting with improving range of motion. So joint mobilizations, we needed to get that foot moving. So hind foot, midfoot, if you can think of a joint mobilization, I probably did it. So targeting really anything we could to regain dorsiflexion, plantar flexion, inversion, eversion, all that. I mostly had him focus on some soft tissue work at home. And then here's some exercise examples. So triple flexion is a nice way to kind of get folks all lower extremity post-op, hip, knee, ankle back to the term is called like control training, where you're just retraining the knee how to be a knee, the ankle how to be an ankle through a pain managed range. And then after a couple weeks of that, I'm sorry, a couple sessions of that, you can add your anterior to posterior glide of the talus. Working on gastroc length, of course, bend the knee soleus length. And then I was really just careful about educating on passive range for his inversion range, not cranking it, right? So we talked about more like lower load, long duration holds. We talked about consistent stretching over time versus like one big painful stretch. And he did fairly well with that. Here's some strengthening examples. So he really, like he said, did not like routine. So getting into a strength routine was a challenge. So I, again, tried to use a lot of analogies, right, with the framework. Say your ankle's a bike. Your bike needs shock absorbers to handle, the rugged terrain you want to be hiking on. So your muscles are your shock absorbers. They're going to help offload the impact through the joint surfaces. I also gave him that goal, 32 reps of ankle plantar flexion. And so having that number, I think, helped him train for it. So single leg calf raises, tried and true, eventually added weight as he was able to. I like this kind of sidestep version with the band around the ankles to work on the E version. Also, heels are lifted, so it's like a 3-for-1 exercise. Here's a variation on a lunge. So any sort of lunge or split squat I love to use because it's multi-joint, it's hitting multiple muscle groups. Then you can add a little spin on it, raise the front heel, which will get at more just ankle stability. Just selected a couple options or examples of exercises. I gave him several more and kind of created what I call an exercise menu. And I said, I hear you that if I give you a strict prescription, it's hard to follow. So here's a menu, build your own adventure. You need to at least choose 4 out of the 8 every time you work out. And that got a little bit of buy-in. Here are some kind of stability balance work we did. So we started with literally balancing on one leg, working on control. And then once that got better, we added some Y balance type of tasks. I would mix this up in clinic, kind of randomize the targets, give him more than the 3 targets. It was nice to use some climbing language with him, right? Like, hey, we're training the back flag here and things like that. This is another favorite of mine. I call it single leg deadlift kettlebell swirl. You can call it whatever you want, but it's just a fun task. And you can say, okay, how many can you do in a row without losing your balance? So it's just, again, working on single leg stability with an outside perturbation. I'm kind of just going through a bunch of examples. This all occurred progressively over the course of about 12 weeks. So I would say at this point in rehab, we're maybe about halfway, maybe a little over halfway. Oops, there we go. So then we started getting into just a little bit more dynamic, a little bit more high level activities. Again, I said we're about halfway, a little bit further. So he's now started climbing top rope indoors. And so far it's going well. He's been able to do that without pain. So we started working towards like the approach type of pain he was having. So with hiking, uneven surfaces. So I tried to just get really creative, give him a lot of options. A lot of step-up variations to kind of reinforce that ankle dorsiflexion, that triple flexion that we had done in the beginning in the lateral plane, the sagittal plane, added some variable surfaces. He bought a Bosu, and he said, if I have it and I invest in it, I'll use it. So that was another motivating factor. So again, you think of the drill, we probably did it, just a lot of variety. This is one I worked on for the rock over type of move when a high foot. He mentioned he was having trouble with this, which made sense with a tight ankle into dorsiflexion. So we would set up a tall box. I would kind of laser point different targets, pretending like he was reaching for a hold, and he would rack up onto the ankle. Usually I would do this after I had done some manual therapy to work on that tail curl mobility and then apply it to this drill. One other thing we worked on was tolerance to falling. So with the ankle injury and that significant lack of dorsiflexion, his landing from jumps did not look very good. So he would significantly offload his surgical side. So we straight up started with a squat jump. So level surface, work on your squat jump, watch yourself in a mirror, practice loading into that surgical side equally as your other side. And then we would put the squat jump onto a squishy surface or an uneven surface. And then we would go to the hangboards and work on progressively higher and higher drops. And starting on an even surface and then landing on a squishy surface. So again, trying to translate these drills into, hey, your ankle needs to be able to tolerate potentially taking a lead fall again. So I adapted what I learned from Jared's course earlier this spring. I think we were presented with like an ACL return to falling, and I remembered it and went to look it up and used it to kind of bring this climber back to falling. So this is kind of the schema. So I would tell him every week or two, try to fall, see how it feels, do your ankle warm-ups first, and we kind of worked through this progression from top to bottom. All right. So where are we now? Numbers are presented here. His plantar flexion strength, so this is the single leg heel raise test, did get better. I'd still like to see it even go higher and higher, like aiming for that 32 or at least equal to his non-involved side. Inversion range started at, I think it was 22 degrees. Not a huge gain, but better than 0, which it was before surgery. And then this weight-bearing lunge test started at 9 centimeters up to 12. Again, not a huge gain. Kind of looking at the status of his joint surfaces, 3 surgeries, you know there's going to be a lot of scar tissue. I wasn't surprised by a plateau in range of motion. So I just kind of hammered home consistent, gentle stretching and mobility, and you have motion, use what you have, but we don't need to force it. So I kind of went through the time progression. Like I said, about halfway through, he went back to indoor top rope. 3 months later, he was back to lead climbing indoor and outdoor. There's a nice little crag about an hour outside of Minnesota, or Minneapolis, with, it's like an 8-minute approach, but it's really steep, really rocky. And he came back to clinic one day and was just excited he did that without ankle pain. He was like, first time I've hiked without ankle pain. So that was really exciting to hear. Throughout this whole process, he picked up kite surfing, slacklining, salsa dancing. I think he was looking for activities to kind of fill the void that he was experiencing. So that made things interesting because kite surfing takes up your ankle energy bank, right? Like there's a lot of dorsiflexion involved. So again, some education on just being smart about which activities to choose when. But overall, he was able to get back to pain-free walking, pain-free approaches. He's still, like, if he walks most of the day, I think he was just traveling internationally and was on his feet 10 hours a day, like that will still cause swelling and soreness. So next time he comes in, we're going to talk about some things to do. Like we haven't even tried taping. We haven't even tried compression socks. So things to kind of mitigate some of that ongoing swelling and pain with walking. But as far as getting back to climbing, I think he really appreciated having a provider that knows the sport and was able to kind of level with him about the realities of his current condition after 3 surgeries and a very large injury, but kind of show him there's things he still definitely can do, both indoor and outdoor. That's my case. It was really, really exciting to kind of apply some things that I'd picked up, through my experience as a clinician in my outpatient clinic, tied with some things I've kind of picked up through this community, and then have a person that found me on this community's website. So it was a fun patient to work with. Thanks again, Jared, for kind of opening this door for all 3 of us. And yeah, question time.